Well, I'm assuming that because everything is quieting down, this is a natural segue for me to introduce our lecturer today. First, just a bit of housekeeping. This is a CME evaluation and event, and for those who do want CME credit, we're encouraging everyone to fill out a survey at the back of the room that it's part of our accreditation process for CME. I just wanted to spend a minute before I introduce Dr. Zitter to just tell you a little bit about the source of this lecture series. The lecture series is called the Ungerleider Palliative Care Lecture Series, and this is the inaugural lecture in the series. And the Ungerleider Lecture Series is part of a larger educational gift that was granted to us by the Ungerleider family, and the goal is to enhance resident education in palliative care and to enhance public education and community education as well in palliative care issues. And we're fortunate enough to have one of the Ungerleiders here, Shoshana. I wanted to acknowledge Shoshana was a former resident and is now a hospitalist and is deeply passionate about palliative care. And I just wanted to acknowledge your presence here. I didn't mean to embarrass you. And now I'd like to introduce Jessica Zitter. Dr. Zitter is a new friend and colleague. Dr. Zitter did her undergraduate at Stanford, went to medical school at Case Western, went back east and did her internal medicine residency, as well as some post-residency training back at Brigham and Women's and Harvard before coming back and doing a critical care fellowship at UCSF. And now serves as an intensivist at Alameda County Medical Center or Highland Hospital, where she has also become a palliative care physician. She is boarded in more things than I can count, including internal medicine, pulmonary and critical care medicine, as well as palliative medicine. Dr. Zitter, many of you may have read her work in the New York Times blog. She's a regular contributor to the New York Times. She's also had articles in The Atlantic and a range of other publications. And she's, my personal appreciation of her work really is that she is a firebrand when it comes to changing public perceptions about care near the end of life. And so with no further ado, Dr. Jessica Zitter.
Thank you so much. Thank you so much, and thank you so much for this wonderful chair that you've awarded here. It's a pleasure to be here. In fact, I think some of our critical care residents and fellows actually come from CPMC, so I don't know if any of them are here, but I don't see them, unfortunately. But I appreciate being called over and would love to take this time to explain a little bit about what it's like. I'm sorry, I hope that people can hear me. Is this okay? Are you okay? Okay, great. So I'm actually just going to start out by taking you to the spring of 2003. I was a new critical care attending at UMDNJ in Newark, New Jersey. And I was a few years into my career, and I had been called to see the patient in bed 5, who was a 54-year-old woman. I apologize, hold on here. Who was a 55-year-old woman with metastatic lung cancer and possibly some septic shock. She was hypotensive, and they asked me to put in a Swan because they didn't know what the source of her hypotension was. And so I had been told that her coag studies were normal, which I confirmed on the lab, well, we didn't have a lab system at that time, but in the chart. And I was told that her husband was prepared and ready to sign the consent form, which I then had him sign off, and he was waiting nervously in the waiting room. I feel like this is not quite, it's okay? Okay, Thank you, sorry. So I brought my catheter kit into the room, and I proceeded to set everything up. I sterilized the patient's neck. I set up my kit with the lidocaine all drawn up, and the flushes, and the balloon was checked and ready to go. And I gowned and gloved, and I laid out a huge blue drape with the help of the nurse and the medical student. The patient, who had been quiet during most of this time, when I turned her head over to the left, moaned, but otherwise was quiet. And I was getting ready to insert the needle. All systems were go. I asked the nurse to put her into Trendelenburg. And at that very moment, this woman was standing in the doorway of the patient's room, and she did not look happy. And it was Pat Murphy, who was an advanced practice nurse at UMDNJ with palliative care training. And she ran the family support team at our hospital. And she and Dr. Ann Rosenthal, who's a trauma surgeon, now currently the chair of surgery at UMDNJ, had won a $1.5 million coveted grant from the Robert Wood Johnson Foundation to study whether enhancing communication in the intensive care unit would improve patient outcomes. And this was a very unique grant. Only 4 sites had won this out of 422 applications. Ira Byack was the person who was in charge of this grant. And I didn't really even know about this reality, but I had been exposed to Pat and her minions of family support who had come in regularly to the intensive care unit and would criticize what we were doing. And I found it very frustrating and irritating. I thought, who is she? I'm doing my best. I've been trained to help these patients. This patient needs a Swan Ganz catheter, and I'm going to do it as safely as I can. And Pat would frequently come in and criticize what I was doing. And so this time, when she was standing there, I thought, oh my gosh, here we go again. And she took her hand to her ear as though she were holding a pretend telephone, and she said, 911, get me the police. They're torturing a patient in University Hospital intensive care unit. But this was I had a different reaction than I had had every other time. This time, it just came crashing down around me, and my veneer cracked, and I realized that she was right. I knew that this patient was going to die, and I knew that my procedure that I was doing to her was not going to do anything more than keep her husband away from her for those 2 hours of whatever precious time she had left. But unfortunately, I could not figure out how to undo it. I could not figure out how to take this procedure off of the train tracks that it was barreling down. The medical team was waiting for the line. The nephrologists were out there twiddling their thumbs, waiting for me to be done. My medical student was standing next to me expectantly. The nurse had the flush ready to go. The husband was worried and waiting in the waiting room. And I just could not quite get my head around how to not do this procedure. And I, to my chagrin, did do the procedure. It certainly did not change the patient's life, but it changed mine. Would that husband, I questioned, have ever agreed to put this catheter in, this Swan Ganz catheter in, had I explained that, yes, I would be gaining access to her hemodynamic system and measuring pressures, but it was not going to change her outcome. It was instead going to cause suffering, and it certainly would prevent him from being next to her for whatever time she had left. She ended up dying the next day, and I really will never forget that case, because it really was a turning point in my career. So I turned to Pat in those early years of the 2000s to begin my training in palliative care as an apprentice, really. There was no palliative care fellowship in 2003. I didn't even really know what palliative care was, but I just knew that Pat had something that I wanted and I needed to learn how to do. And she and her team taught me how to break bad news, how to sit with discomfort, how to let reality set in for people and sit with them while they processed it, how to deal with people being angry and disappointed in me. And how to work with them to determine whether the procedures that we had to offer were really what they wanted. And it was very difficult because families were often shocked and angry and disappointed that an ICU attending might be saying that actually this Swan Ganz catheter that was recommended to you by this other doctor or this Quinton catheter that was suggested may not actually be in your best interest. They would be surprised. Why would you say that we shouldn't do this if it was recommended by another doctor? But eventually, I would say in most cases, people eventually were appreciative, and obviously it changed decisions in a lot of patients as I went through my training. The objectives of this talk, which you might be starting to pick up on are to highlight the concerning tendency of doctors, not only ICU doctors, but any doctor, including primary care doctors, to hide behind interventions rather than to talk to patients. And I obviously am encouraging honest and direct communication with patients in all locations, whether it be the ICU, the oncology suite, the pre-op suite, and primary care visits, to allow patients to really understand what is going on and what the options are that we are offering, and allow them to have the opportunity to opt out. So I want to start a little bit with my own career as a case study of how even a well-meaning doctor can perpetuate patient suffering by hiding behind interventions rather than communicating with their patients. And as my residency grew to a close in 1995, I had to choose a subspecialty. And you ask why I had to. Well, at that time, at the Brigham and Women's Hospital, there were only 3 out of 60 people who went into primary care. And of those 3, 1 ended up going into gastroenterology. So it really felt like there was something to be done. I had to pick a subspecialty, and nephrology was, frankly, just too complicated. Too many pumps, too much chemistry. Infectious disease required too much patience for me to sit down and piece together all of the different resistance patterns of a nursing home patient. And pulmonary and critical care just spoke to me. It had a lot of offerings. I could be in the clinic, but I could do a bronchoscopy, then I could run over to the ICU. And I understood the physiology of the lungs, the physics of the lungs. It made sense to me. So I chose pulmonary and critical care. But I will also admit that I actually kind of wanted to be like these guys. They seemed heroic, and they were lifesavers. There was nothing mundane about what they did. Every action seemed to count, and in the 11th hour, they always had something they could pull out of their bag to save the day. And I wanted to be able to do that. I loved the tools. I loved the tricks. And the ICU was a place to be a lifesaver. How many doctors really can say that they actually saved a life in real time? Certainly, ICU doctors can. And the iron lung was one of the first of these tools. Obviously, in the 40s, late 30s and 40s, when patients were dying, children were dying by the hundreds and thousands of polio, to be able to put a child into a iron lung and allow them to continue to breathe was miraculous. Obviously, you needed a place to put these huge machines, and you needed a trained staff to manage them, and thus was birthed the modern ICU. Around the same time, in World War II in Korea, doctors were learning how to save lives of soldiers on the battlefield. And they would actually bring their MASH units as close as 10 miles from the fighting, and they would scoop soldiers who were hemorrhaging off of the battlefield and bring them back to resuscitate them in these little MASH units. And so many, many soldiers were saved, lives were saved, that would certainly otherwise have been lost. And so something extraordinary in these 1940s, the years of the 1940s, was happening. It was heroic, and doctors were suddenly able to intervene with machines and other aggressive types of interventions to restore lives that would have been lost, of young people, of soldiers. And so if a little is a good thing, you can imagine this just became, it ran rampant with it, and suddenly ICUs were everywhere. And by the 1969 or so, most United States hospitals had at least one ICU, and now in 2015, more than 6,000 ICUs in the United States for 5,000 hospitals. They were spawning. So we know we've got a whole vegetable soup. You all know in this room that this is only a fraction of the types of subspecialty ICUs that exist right now. And for each of these ICUs, there's a whole armamentarium of tools which are different and require different skill sets that exist out there. And the problem is that we've become indiscriminate about how to use these tools. And we've begun using them on everybody, even people who are clearly dying. And we've really forgotten the art of letting people die, which is something that doctors used to be very good at, because everyone does die, and people who are dying are often under the care of a doctor. And what I think, unfortunately, the term antechamber of death comes to mind. I feel like when I'm on service in the ICU, I have just maybe half of my patients, maybe half of my census is patients who are dying. And I feel like we're going down the wrong direction. We have been going the wrong direction with this issue. As much as I love ICU medicine and I have saved lives and restored people to health, unfortunately, this is much too large a part of my practice. This is a rendering of what I call the end-of-life conveyor belt. So if everything goes as expected, seriously ill patients will die in the ICU attached to all manner of life support. There are exceptions, of course. Sometimes people have opted out for whatever reason, and they don't come to the hospital to die. That's a wonderful case scenario. Sometimes patients just happen to die before they reach the hospital. But of patients who are hospitalized, this is a pretty common scenario. And there is a small group of patients who do opt out, who are hospitalized, patients who have DNRs. As we know, the data on DNRs show that they're only written very, very late in most patients' hospitalization. But nonetheless, there is a small and hopefully growing percentage of patients in the hospital who are dying who do not end up coming to the intensive care unit. But of course, there are also those patients who die on the floor before they make it to the ICU, but many of those patients have undergone codes. And the code process, which I'm assuming most of you have some experience with, is not great in terms of its outcomes, and I will give you some data on that in a little bit. So avoiding death in the ICU is generally, it takes luck or a lot of planning, but it's certainly not the default. Joan Tino did a study that came out in JAMA in 2013, which looked at this phenomenon of conveyor belt deaths, as I call them, deaths which occur either in the ICU or very recently having been discharged from the ICU. And she looked at 800,000 Medicare patients over the age of 66 who died in 2000, 2005, and then 2009. And what she found was that there's been an almost absolute rise of 5% of patients dying in this location, which is a very concerning trend. What are we doing in the ICU? What's happening? What are some of the things that are contributing to this phenomenon? The ICU is a place, as we all know, where we try to jumpstart bodies, whether they're children with polio, soldiers, or dying patients. And our tools are very supercharged. They're too unsafe to use on the floor. We don't do those kinds of things on the floor, so we have to bring these patients to the intensive care unit. And we spend a lot of energy on those kinds of procedures, running in and out of rooms, shocking patients, putting people on pressors, putting lines in patients, which is a very common activity that we do. What we don't do is take the time to talk to our patients and to provide them with realistic information about what's going on. And so our patients are actually very in the dark. It's a very emotionally tense environment with a lot of pressure and very little communication. Everything's an emergency. There's always an organ that's failing that we can be attending to. And talking, as we know, is very difficult and very messy and very stressful for patients who are already stressed. So we tend, as doctors, to focus in on our procedures, and the patients tend to sit and wait for us to do our procedures. And there isn't a lot of communication that's going on. We really, as ICU physicians, and I can attest to it certainly in my training and even in the training of some of my residents, it's not something that commonly is taught. Medical students are starting to do more of that education about how to break bad news, but it's not something that a lot of my residents and fellows seem to be very comfortable doing, and certainly my colleagues and myself. It takes a lot of work and a lot of energy, and it's pretty counterintuitive. You don't want to walk in there when someone is really suffering and break bad and disappointing news. The procedures that we have are very glittery, and they're very attractive. They're I would almost say addictive because they're fun. They're satisfying. They come packaged in what looks almost like a TV dinner box. They're clean, they're organized, they're predictable. There's syringes to set up, there's sterile fields to prepare. Doing a procedure is very soothing. When you have a sick and dying patient and you feel anxiety about it and worry, you can come in and really focus in on this procedure, and it really feels like you're getting something done, like you're helping. It's a relief. And cleaning up is really easy from these procedures. The needles go in the needle box and the blue drapes go in the trash. And it's very, very difficult from cleaning up after a discussion, breaking bad news, interacting with the family. That's much more difficult. That takes an unpredictable amount of time. It takes being prepared to deal with unpredictable emotional responses, and it's just much more complicated than doing a procedure. And this is another little rendering, but the scales here you can see are very much stacked or tipped towards intervening. We're trained to do it. We're very confident. It's pretty easy to do them well. The risks are low, relatively. We are expected to do it by the families. They're almost expecting us to have some kind of an offering. And our colleagues are expecting us to do these things. They're surprised if we say, I think we need to hold off on this. That's a surprising thing for an ICU person to say. And I think a lot of times people look at you askance. I certainly have had that experience myself. And sitting down and communicating, frankly, breaking bad news is sometimes a very unattractive option. So I want to talk a little bit about the Swanganz catheter, which was the catheter that I was telling you about in this initial case that I was mentioning. The Swanganz was developed in the 1970s by Swan and Ganz, and it was theoretically, it was a way of differentiating between the various types of shock. It wound into the heart and allowed you to differentiate between a septic cause, a vasodilatory cause, cardiogenic cause. And it was theoretically helpful, more safe, because the balloon at the tip of the catheter, these very pointy catheters, inflated and provided a little bit of a cushion so that as it was going in through the heart, it wouldn't be as likely to pierce the cardiac muscle. And so now, in the 70s, when they developed this strategy, this new type of technology, catheterizations could be done not only in the cath lab by a cardiologist, but by ICU doctors, and became very rapidly co-opted into the ICU culture. And by the mid-1980s, we were using about 40% of all ICU patients were getting Swanganz catheters at a cost of about $2 billion a year. If you don't mind, if I read you a quick piece that I wrote about placing a swan, it was really, the procedure was almost a religious experience. Physicians were dressed to the nines in full sterile regalia, bouffant caps, face shields, masks, long blue gowns, gloves, and shoe coverings. The room was like an ocean, almost everything, including our patient, covered in blue sterile drapes. We prepped the patient's neck, the only body part left visible, with 3 rounds of betadine swabs. The sterile kit was unwrapped and waiting at the bedside table. Needles lined up, syringes filled with lidocaine and saline. And then, when all was ready, 2 physicians, one often training the other, bent over the patient at the head of the bed. Others would stand at the entrance to the room, away from the sterile field, to observe the sacred moment when a doctor would enter a patient's heart. As we threaded the catheter in, we turned up the volume on the monitor so that it beeped with every heartbeat in order to alert us to any change in rhythm, which might foretell a dangerous arrhythmia. The monitor displayed the pressure readings, waves rising and falling as the catheter crossed from the superior vena cava into the right atrium of the heart, and then into the right ventricle, and eventually into the pulmonary artery, where it would be parked for days, sometimes longer. When the tip of the catheter had finally passed out of the right heart into the pulmonary artery, its resting place, we all breathed a sigh of relief. And I just remember, as a resident and a pulmonary fellow, putting these in, and just the thrill of it. felt like you were really doing something, and you were really helping, and you were lending your expertise to a dying and suffering patient. And it really was soothing, honestly, to the operator. And as I said, they were rapidly adopted. There was no real trial. They were just rapidly expanded, and as I explained, 20 to 40% of all ICU patients, $2 billion in Medicare spending annually. It became a verb. I swan, you swan, he's a good swanner. And it was a rite of passage. It was a basic competency. So that's the swan, but I want to switch to a different intervention that's more recent. It's less glittery, perhaps, but it's also having and maybe for that reason, it's having a lot more trouble being adopted into the ICU culture. But it really seems to work. Palliative care in the intensive care unit. This is a great review by Rebecca Aslickson at Johns Hopkins, who's an anesthesiologist. The basic overview of what it is that it's a patient-centered approach, not location-centered, not operator-centered. And it's based on the patient's need. And it ideally is integrated into the ongoing medical care, not just sequential. So you don't just flip to palliative care once you've exhausted all of your tools in your ICU chest, but you actually bring it in as part of the experience of taking care of a critically ill patient. The goals are to improve communication and education for patients and their families, to alleviate distress, and we're very successful at managing symptoms of all sorts, to help identify the goals of care based on patient desire and values, and to help align medical decisions with the goals and the values. And I will tell you that this just doesn't happen a lot in the intensive care unit. It really doesn't. And palliative care, I'm not going to get into it in too much detail, but there's a lot of effort to get it into the ICU. And whenever I go to an AAHPM, American Association of Hospice and Palliative Care Medicine meeting, I always marvel at the number of sessions, people trying to strategize how to get their palliative care teams into the intensive care unit. It's almost like they need a Trojan horse to do it. It's really hard. It's hard even for me as a ICU physician to bring my palliative care perspective into the ICU. When it's my patients and I'm rounding, I can do it a little bit more easily, but sometimes I'm still met with my residents and fellows by this strange look of, what? They don't quite understand that it's a different philosophy than just, we've got organ failure here, let's do this. We've got, a need for a Quinton catheter here. They are not quite used to this paradigm. So it's very hard to bring palliative care, at least in my experience, into the intensive care unit. It's getting easier with time, and I think I'm curious to hear what people say about how it's doing here, but it's a tough nut to crack. Let's see. Palliative care improves symptoms and outcomes in the intensive care unit. And I'm not going to go through all of the details, but I'm going to give you a quick overview. It improves symptoms, as I mentioned, about a 90% success rate in managing symptoms. It reduces rates of unnecessary treatments and hospitalizations. It significantly lowers the intensity of care, which I'm going to show you in a second, and reduces costs. It causes significant relief among staff taking care of critically ill patients to have palliative care involved in terms of making them feel like they are being more patient-centered and being supported to be more patient-centered. And it improves family satisfaction and bereavement. A lot of data coming out on post-traumatic stress disorder for bereaved family members. That's significantly improved with the use of palliative care consultation. It enhances the continuity of care. As you can imagine, patients don't fall through the cracks as much. And it does not affect mortality, does not shorten people's lives. Here are a couple of studies I want to show you. Norton, in 2007, looked at 191 terminally ill patients who were really sick. They were either age greater than 80 with 2 systems very seriously down, 2 organ systems, or they were on greater than day 10 of an ICU stay, or they had an active stage 4 malignancy or intracerebral hemorrhage on mechanical ventilation. So these were very sick patients. And they did a prospective cohort study. They started off with 65 usual care patients who just had the regular usual care, and followed up with 126 patients who received a proactive palliative care consultation if they had one of those diagnostic inclusion criteria. And they found just a striking drop in the use in ICU days from 16 days to 9, with no change in 30-day mortality. Another study looking at patient-centeredness. This isn't necessarily palliative care, but the patient-centeredness component of palliative care, looking at the quality of communication scale, which is a really interesting scale. They looked at 230 surrogate decision makers of patients on mechanical ventilation, and they surveyed them, and they found that those who had a better understanding of what was going on with their loved one tended to choose less intensive treatment. For every 5-point increase on this quality of communication scale, there was a 12% decrease in the amount of time spent on life-sustaining treatment, again, with no significant change in mortality. Oops, excuse me. Let's see. So another concerning finding, which is not surprising, I'm sure, 8% of these 429 geriatrics patients had never discussed code status with their doctors in this Canadian Family Physician article in 2012. So if you look at healthcare providers, on the other hand, they tend to die differently. They have very different preferences for CPR. 88.3% of doctors surveyed in this Pericoil, I don't know if you know VS Pericoil down at Stanford, has been doing some very interesting research. Of these 1,081 physicians that she surveyed, 88.3% of them said that they would opt to be DNR themselves if they were terminally ill. And so again, compare this, I'm just going to go back, to 8% of patients, geriatrics patients who's ever had a conversation about DNR with their physicians. So this woman is a woman that I met at the UCSF Mindfulness in the ICU conference. I don't know if any of you were there, but it was a very interesting conference, mostly nurses. There were a few doctors, but would love to see more there next time. And this woman told me that, she said, I'm not letting them touch me. And I said, what do you mean? And she said, well, I have a tattoo. And I said, what do you mean? And she pulled her shirt down and showed me that tattoo. And I'd heard this threatened many times by healthcare workers, but I'd never actually seen anybody really do it. And I was fascinated, but she said, I just know what happens and I don't want it. I wasn't 100% sure that I agreed with her, but she was pretty firm. Here's an interesting study that came out of 1994 in the New England Journal, looking at what patients actually choose if they know and understand CPR, if they really understand the concept. Most patients tend to overestimate the likelihood of survival after CPR. And when they do understand, number one, the procedure, and also the likelihood of survival, which is 10 to 17% total, and 0 to 5% of patients who are terminally ill, they're much less likely to want to be resuscitated with cardiac resuscitation methods. And they looked at 371 patients over the age of 60. 41% of them at the beginning said that they would want CPR. But after they were taught about what CPR is, only 22% of those wanted the CPR. When they were given a scenario of being chronically ill, 11% of patients said that they would want CPR before they were taught what it is, and then after that, only 5%. So patients really don't understand what CPR and a lot of our procedures are. And when we explain what they are, they often opt out and don't want them. And they often, and therefore, are able to have the experience that's more like their physicians. So knowledge changes behavior. patient-centered decision-making in the intensive care unit, whether it's initiated by an ICU physician integrating patient-centered concepts or it's brought in by a palliative care consult, changes the experience of an ICU patient, and they will be much less likely to choose life-sustaining treatments and intensive treatments at the end of life. So let's just get back to the Swan. Here, the Swan didn't do very well. In 1996, Connors produced a retrospective analysis of actually, interestingly, data from the support trial, which, if any of you have heard about it, was the initial study looking in 1991, I believe it was, at death in America and the sad state of death in America. And this was a reanalysis of some of that data. And Connors showed that the Swan not only didn't benefit our patients, but actually increased mortality by 24%. And then what followed after that were multiple randomized control trials, which essentially all confirmed that the Swan, which we had been using with such verve and gusto, was really not indicated in almost all conditions. And we essentially don't use it anymore for the most part. Sometimes in cardiac anesthesia it's used, but it's really not used very often. And it was abandoned very quickly. There was a 65% decline in the use of Swan Ganz catheters between 1993 and 2004. And so it really teaches us an important lesson about the seduction of technology at the cost of our patients. So I'm going to wind down by just bringing you back to my story. The more I started to practice both the ICU medicine and palliative care at the same time, the more I noticed and became concerned about my instincts as an ICU physician. And I have really strived to change that, but it continues to be difficult and a challenge. And I began to write partly to commit myself to not falling back into old patterns and to try to keep myself honest. What I've been so encouraged to find is the number of ICU physicians who feel the same way as I do, and I'm feeling very optimistic about the future. The concept of see one, do one, teach one, which many of you may have heard about, which refers to teaching a resident how to do a procedure. You see one procedure, then you do one yourself, and then you're competent. You're considered competent. Well, I would put forward that that's something that we can also use for physicians learning how to speak to patients. That you can see somebody do a breaking bad news or a conversation about reality of prognosis, and then you can do one, and it's tough. And then going forward, you can teach one. And I'm seeing that amongst our trainees and feeling, again, encouraged that things are starting to change. And my final slide is to just say that we physicians need to do unto others. And remember, we need to let our patients have the option to die the way we are dying as physicians. We need to be patient-centered, regardless of location. Just because someone's in my ICU doesn't mean that they will want to have a Swan Ganz catheter or some other type of procedure. I would say that we must be very careful not to hide behind our technology. And we need to learn about alternative visions of hope and other types of medical care, of which there are many, and which I thank Pat Murphy for teaching me. And for difficult cases, of which there are many, you must seek help because it's really difficult to do this by yourself. Lastly, just to say, provide your patients with the bigger picture of what's going on with them and give them the option that we all have of opting out of the types of treatments that we have just been defaulting to for so many years. So with that, I want to thank you so much for having me and would love to hear some questions or discussion.
Hi, Jessica, that was great. Really nice talk. My name is Jennifer Brokaw, and I was an ER doctor.
We went to college together, I think.
We did. And I'm also very interested in this topic. I went to a talk at Stanford on Monday, with Atul Gawande, whose book, Being Mortal, is #1 on the New York Times bestseller list. Yay. So I think that there's this incredible desire on the part of the public to talk about this. And at the talk was a legendary businessman named Charles Munger. And he made the point that until we undo fee-for-service medicine, the train is going to stay on the tracks, and the catheters are going to get put in, and the scopes are going to be done, and the surgeries of unclear benefit are going to be performed by physicians who feel that they are doing the right thing for patients. But on some level, our whole system, our doctors and our hospitals are so perversely incentivized still to this day that we're really fighting, we're spitting in the ocean until that is undone. And that was a point that really caused the audience to sit in silence. It was mostly physicians in the audience. And I'm wondering, what your thoughts about that is.
Yeah, well, I will tell you a quick story, very quick story about having dinner with a friend of mine last week who was a gastroenterologist and works at a vent facility and was pressured by the vent facility to put this PEG tube in, which he didn't want to do and which the patient had not wanted. And when the patient became unconscious, the family was pushing for it. And I agree with you. I mean, I think I don't have a solution to the healthcare system. I think my husband probably has a better sense of what we should do for that. But I really do think fee-for-service is a temptation. I know that when I'm filling out my RVUs, even if I'm not thinking about the money, I feel productive. I clicked off that I did a Swan Ganz, or I clicked off that I put in a central line. At the end of my day, every day, even now I work at a county hospital, I feel like I did something if I did a procedure. So I don't even know if it's only about the money, but I think it's a part of it.
Right. Anyway, it's worth bringing up.
Yeah, definitely.
I'm a hospitalist. I'm Andy Knapp. I work mostly at Davies, but while I think there are a lot of reasons to reconsider fee-for-service, I think that sentiment really does a disservice to the vast majority of ICU physicians I work with. For one thing, on the money end of it, I believe at the very least, even as a rounding hospitalist, my billing level goes up for a palliative care DNR decision with the family. And I'd say the majority of the ICU physicians I work with here give some pushback when the patient is obviously ill, the situation is futile. So I'm sure there are physicians for whom the financial incentive is a big part of it, but I think a much bigger part is what you've alluded to, the naive expectations of families and the fear of doctors of confronting death and giving families the truth.
Yeah. I think it's multifactorial. It's so complex. I hesitate to really put much into it. I mean, I just want you to see from this piece how seductive it is to do a procedure. It's seductive. It just taps into some soothing behaviors. It's very calming.
Agreed.
Yeah.
Thank you so much. I think you speak for many of us in the room. I wanted to ask a question, looking around the room right now and seeing the variety of different disciplines here, social workers and chaplains, and hearing your talk. It's an incredibly compelling talk from a physician's perspective, and I'm hoping you might be able to reflect back to us about how hospitals and healthcare systems might be able to make better use of the other experts on our teams, meaning our chaplains, our social workers whose jobs really are to be supportive and healing for families and patients who are going through these really difficult times. So maybe I'll just put it out there.
Yeah, I mean, I think there's a hierarchical structure in the intensive care unit which is very, it puts doctors in a very difficult position. When I'm working on the palliative care team, or even if I call in a palliative care consult as the ICU doctor, I feel a tremendous amount of support in thinking through how best to approach a particular situation. If I'm doing a hierarchical approach and it's just me at the top making decisions, I'm much more likely to default to just doing something because I don't want to err on the side of not taking care of my patient. So I think having a sort of group of smart people around you, and I include my chaplain, social worker, talking about the case from a whole variety of perspectives is tremendously empowering to me as a physician in terms of really being able to step back from a case and think about what the right thing is to do. And I have learned so much from our chaplain and our social worker that have been empowering for me.
I just forgot to mention what's perhaps the most important member of the ICU team, which are the nursing staff.
That goes without saying.
That goes without saying.
Yeah.
And I just wanted to make one other comment, and then I'll pass on. I really appreciate this question about fee-for-service medicine. And what it brought up for me was a lot of the comparisons that are now being made between palliative care and issues around the birthing movement back in the 60s and 70s, where it took a tidal wave of public sentiment to pushing against the domination of decision-making around who could be in the room and the rates of C-sections and all of this stuff, to push towards a more shared decision-making process with moms and dads and physicians. And I'm just wondering what your feelings are about the role of actually the public driving the changes versus this being driven from within.
Oh, I mean, I think it's an excellent question. I think it's so much of this is going to be lay-led and lay-driven because the lay public, as you can see, is not getting what they're not dying as well as we physicians. We don't have the same pressure of time. I think if the lay public understands what the data are, they're going to feel more and more pressured to take some decision making into their own hands, I hope. But I think it's the wheels of change. Medicine is changing, medical culture is changing, and I'm seeing a lot of, as I said, optimistic signs that things are changing. But I don't think the wheels of change in the medical culture are going to be nearly as rapid as many people out in the lay community are going to need. So I hope that they're going to start to understand that, get that message, and start being demanding change.
Thank you so much. That was really consciousness raising. We appreciate it. I'm Larry Vivian. I'm chair of medicine here and had a small hand in bringing you. Just two brief comments. One is that there is a growing movement toward what we call high-value healthcare. In England, they call it clinical outcomes or effectiveness research. And I really am grateful that you showed us data on the outcomes of resuscitation efforts, on the clinical benefit or lack thereof of once holy technologies such as Swan Ganz, and additionally how information deployed to patients affects their decision making. And to me, this should be viewed much as all other forms of evidence-based medicine, of high-value healthcare, meaning that we want to deploy resources where they will produce benefit that's concordant with the values, wishes, and goals of our patients. And I would love to see some more explicit linkage of palliative care with the high-value healthcare movement, which I think is gaining a lot of traction. The second comment is, and forgive me if this was already addressed, that we're starting a pilot in next month. I don't know if Catherine is here. Can you, I'm sure, could elaborate on ICU-based palliative care consultation for all comers to gather some of our own internal data and examine our own culture around when and how we utilize palliative care in the ICU and how this might affect our ability to deliver care. So we hope to have some data of our own before too long.
Right.
Yeah.
It's fantastic.
Thank you again.
Thank you. I'm Monica Rosenthal, and I'm the palliative care educator here at CPMC, and am proud to say, I'm sorry, I'm proud to say that thanks to the same grant that has supported this lecture series, we are now offering a pilot program of education in communication skills for internal medicine residents so that they can become more comfortable whether they're going into ICU medicine or a subspecialty or primary medical care, so that we can try to turn around that lousy percentage that you showed us in the slide of geriatric patients that have been offered a goals of care conversation. We want to change the culture of physicians not feeling comfortable having these conversations. Part of that has to come from education, and part of that has to come from incentivizing. And as has been mentioned before, one of the barriers that we are up against is the fact that primary care physicians who currently are being given very short windows in which to treat their patients in the clinical setting are not being reimbursed for having goals of care conversations. Medicare is currently weighing a bill, the CMS is currently weighing a bill that would allow Medicare to reimburse primary care physicians for doing goals of care conversations. Anybody that is sitting in this audience that is a voter, please find out who in Congress is representing you and urge them to vote for this bill. Thank you.
Great, thank you. Yeah, unfortunately, Sarah Palin scared Obama from, had to take that out of Obamacare the first time, so maybe we'll do it better the second time.
Yeah, hi, my name is Reine, undergrad associate psychology major. I just have a question that, inform the patient about palliative care or hospice care is really important for the family members to have different types of care and then get to say goodbye instead of losing them during the surgery. But when that's really good opportunity that they get to talk about how want to spend their last time. But then whoever does not have family members or relatives or friends, that they already feel like this is meaningless and life is just helpless. And in that time, if doctors or hospital offering or telling them about palliative care, hospice care, and they would feel like, okay, now I can die, finally. And would that be a good death or nothing is a good death, but kind of better death that we palliative care or hospice care was looking forward to, but was still kind of just sad and waiting for it to die. So, I believe that inform patient about palliative care is really important, but in that case, would it be still important to them to know about it or have a different care, psychological care first, and then palliative care, information about palliative care is good for them? I'm sorry, I'm kind of going, yeah.
Are you saying that you're worried that palliative care or knowing that they're going to palliative care might make somebody depressed? Or are you saying you want to make sure someone's not depressed before you send them to palliative care?
Yeah, sometimes people just already feel like this is meaningless, life is meaningless, I want to die, but hospital is keeping me here, but I don't want to live anymore. But in that case, palliative care might lead them to, okay, now I can finally die, and would that be still a good death for themselves? Because if they have a family members to talk about it, would that be really great that them to talk about those things, and then they know that I'm still meaningful to them, and they'll still need me. So in that case, it's really good time to have a conversation, even if it's a huge argument. But if people don't have a family members or friends, they're still, what should we do?
I don't totally, I'm sorry, I don't know if I totally understood, but I think you're sorry, can you clarify that a little bit more? I apologize. What are you asking specifically?
So is still good for them to know about palliative care, even when they're thinking about I don't want to live anymore?
In other words, if they don't have a terminal illness or something that is causing them to die?
Yeah, let's say they have cancer, but hospital is thinking they can fix it.
Oh, absolutely. I think that's exactly the moment where you want to give that as one of the options. I think it's a really important part of the entire offering that we have. Palliative care is one mode of helping patients through terminal illness in addition to our traditional hospital methods. So definitely.
Yeah. I worked in the emergency room for a number of years, and I think one of the best things I ever heard a female physician say to the patient, who had a DNR and then changed his mind and wanted everything done. And she said, I will do everything you want me to do. And she explained intubation.
Central line?
Yes, central, thank you. It's been a long time. Central line. And she said, I will do everything you want me to do. These are the procedures. This is the discomfort. But I want you to know, at the end of all this, you are still going to pass away. Mm-hmm. It's not going to make any difference. It's only going to make a difference in how much you can tolerate.
Mm-hmm. Mm-hmm. And what did they decide to do?
Actually, that made a lot of sense to me. Mm-hmm. And it made it a lot easier to speak to a lot of the patients that we had.
Yeah, I think it's a good point. One of the things that I believe is that a lot of people have no idea what it really looks like to die in an ICU. And one of the things that I find myself sometimes doing is getting, I don't like to use the word blunt, but honestly it's a little bit blunt about really being descriptive, because I think if people don't have a visual, and maybe it should even be through a video, not necessarily just through words, but really seeing what it looks like to be in an ICU on a breathing machine, I don't think that they're really armed with fully informed sense of what they're getting themselves into. And it may be a radical proposal, but I actually wonder if maybe before people can get health insurance, they should actually have to watch some of Angelo Volandez's videos that are coming out of Mass General about end-of-life issues, because I think we have a lot of patients coming in and thinking that they know what it means and having absolutely no idea. And then by the time they actually might figure it out, it's too late. So I think it's important to be descriptive in some way to patients.
Hi. Oh. I'm Janet Diaz. I'm one of the pulmonary critical care docs here. So
I've heard of you.
I've heard of you as well. I really enjoyed your talk, and I had a couple comments. One was about this communication piece and being brutally honest, I feel. I had an experience recently where I came onto service and a lady with advanced pulmonary fibrosis had been intubated for about 2 weeks, and I was calling the family just to update the situation. They wanted to hear from someone, and I was the new attending on the service, and I wanted to make the call, and because she wasn't really advancing, she wasn't weanable, and they're like, how's she doing? And I'm like, she remains critically ill. And they're like, oh, but that machine, she's breathing on her own. I'm like, no, the machine is completely breathing for her. She's on life support. Mm-hmm. And they're like, what do you mean she's on life support? I'm like, she's on a mechanical ventilator. And I'm like, oh gosh. And they're like, well, what do you mean? I'm like, without mechanical ventilators provide life support. Without the life support, she would die because her lungs are not working. And I was brutally honest because I was like, because they're like, what do you mean she's on life? They were like yelling at me about this life support business. I'm like, she's been on life support for 2 weeks. And this is not good. It's not looking well at this point. And they should know that. And I wanted them to come in and see her. And this is over the phone. And they're like, and then they're like, we just don't believe she's on life support. I'm like, I promise you she is on life support. And without that. And so then they're like, Mom didn't really want to be on life support. Right? And I'm like, I'm about to I don't know, pull my hair out, cry or something. And I'm like, Mom didn't, what do you mean by that? Mom didn't want to be on life support. She didn't want to be on machines maintaining her life. I'm like, have you not been, so then I was like, have you not been to the hospital to see, so we had this discussion. I was like, please come to the hospital. We need to talk. Blah, blah, blah. Nonetheless, but that brutally honest thing, I feel like, gosh, how are we explaining what we're offering to the patients? So to come to palliative care consultation, I believe it should start before you arrive to the intensive care unit, because once you arrive, we are in that mode. We are like, ooh, let's intubate. Ooh, let's put the line. That's what we do. Yeah. And we do that quickly, and to do it safely, early intervention save lives. So that's what we're thinking. But at the same time, we're also seeing with that other, at least I am, and I hope more intensivists are seeing this way. It's like you're also seeing ooh, metastatic cancer patient here, and you're like, ooh, is this really what they want? Or sometimes you're seeing cases where people may have had the forethought of becoming DNR, DNI before they came, and then all of a sudden they're in the dying process, right? And patients get scared, and then they reverse their code status. And you're like, but you already thought about this. Why couldn't we have helped them through that transition of the dying process? Why did all of a sudden we reverse it? And now you're coming to me, so then I could like put tubes in you. Like,
Yeah.
sure, I can do it, and I will do it safely, like you said. That's what we're trained to do. But like, where did we lose as physicians and surgeons, doctors, the caring for patients as they die? And I think that's where you brought it up at the beginning. It's like, that's what we've always done, before many patients died. And like now I'm just like, people die. That's like, we are all going to die. So where is our training?
Yeah.
Like, where have we lost that part of our training? And so now it's like palliative care, which I think is, a wonderful specialty. But at the same time, it's, I think, a training that all doctors should have, not just limited
Absolutely.
to it's like, so the conversation starts before the ICU, and it starts and continues beyond the ICU. I've thankfully saved lives, old patients who've got dementia, and I've, saved them, got them off a ventilator, and sent them on their way. And then I'm like, someone have a palliative care discussion with this patient so that they know what they're going to get into the next time this happens, because it will happen again. Mm-hmm. Yeah. And have that discussion, or I'll have that discussion. Yeah. So, anyways, those are my thoughts.
I totally preaching to the choir here. It's a real problem. I think what Atul Gawande says, and he actually at the plenary session at AHPM, he was just filled with praise for palliative care doctors and geriatricians, which I share. And he said, you're going to have to teach us all how to do this, because this is not something that we doctors really know how to do. And the reality is, and he said this as well, we don't have enough palliative care doctors, and frankly, we never will have enough palliative care doctors to address the needs of the dying patient. We all, as physicians, whether we're oncologists, intensive care unit doctors, whatever, are essentially going to be, I hope, required to have some sense of skills at dealing with helping patients understand what's really happening and helping them make choices that really are commensurate with their personal values. So it's going to be something that's going to have to be integrated into healthcare in general, and physicianship and nurseship and everythingship, and it's not currently. It can't just be delegated to palliative care doctors. Sorry.
I'm sorry. I know we're running way over. Just really interesting, obviously, and I'll try to just keep my comments to two, even though I have a lot to say. My name is Wendy Zachary. I'm a hospitalist here and a geriatrician, and thank you so much for coming, and thank you so much for making this possible. But just two comments. Number one, about brutally honest. I think one thing we can do is teach our residents and each other how to say the word death. Don't be afraid of it. It's not going to bite you.
Agreed.
You may get a weird look from a family member, but once you get over that, just say the word.
That's right.
And then doors open. And then the second piece is that I think it was kind of funny that you put that picture of ER in there, and that was an inspiration for you, because I think that is one of the shows that did the biggest disservice to medicine.
I totally agree.
And end of life and death and dying, because they're beautiful, and some people here are, some of us not so much, and we don't come in, save people from the brink of death every day, and then go make out with each other. Like, this doesn't happen in real life. That isn't what happened, but that's what patients expect, because that's what they see on TV. Totally. They think we're going to come in and put that Swan Ganz in and then save their lives, and it's a lot messier and sadder than that. It's not as sexy, but it's really a lot sadder, and so the media owes us. They did good in the Oscars this year. They brought up dementia, they did all this business, ALS, but the media owes us right now.
Totally agree. Totally agree.
So, hello. I'm Rufina, one of the social workers here, and I think, we do need more teaching, and I appreciate, when you bring it up, it's really a multidisciplinary team. And one thing that I felt like, I learned from school was actually to do my own advanced directive myself, because I don't know how many of you here, actually have an advanced directive done, but I feel like, not only like you yourself go through that process, be able to put into the person's shoes. And I feel like, it's really like starting at the beginning when somebody enters the hospital, when somebody tell you they have an advanced directive, have we honored it? Have we really looked into it? And so, that's kind of, something that I feel like it will be important, when we talked about the teaching, not just talking about how to talk about death, but really think about our own death. It's really alarming when I see that 83% versus that 8%.
Yeah. really alarming.
Thank you.
So my name is Leah. I'm a social worker here as well. And I feel like I've encountered a good amount of patients that I feel like could have benefited from palliative being involved much earlier on than they actually were. And sometimes physicians can be really open to the conversation, but some physicians aren't as open to palliative involvement. And so I was wondering if you had any tips for getting palliative involved with a physician who may be more resistant to getting them involved.
It's so difficult. I mean, again, I've had people joke. I mean, I'm going to be honest. There are people who joke about me. I had a neurosurgeon say to me when I was called in on one of his cases, "Oh, what are you, palliative care? You're here to give me a massage?" It's hard. It's really hard. I find it hard. Most of my colleagues, I would say, in the ICU are great. I've watched a change in our ICU culture because I'm always yapping about it in a good way. Not. I don't mean to say yapping like it's irritating. I'm really constantly talking about it, and I'm trying to change the culture in whatever way I can. And I've seen it change. But there are some physicians, even one of the most resistant doctors is now considering himself to be palliative care supportive. And I just think it's about it's about pushing education, trying to be gentle and calm. Sometimes I feel like getting hysterical and saying, "What are you doing?" But just constantly trying to come in, make people understand that there's a different way of looking at things. Because the truth is, when I said that see one, do one, teach one concept, which I don't know about the physicians here, but I'm assuming most of you have heard that, see one, do one, teach one. Maybe it's an ICU thing, but it's about quickly ramping up to speed on learning how to do a procedure. You see somebody do a good palliative care conversation, good communication, good breaking bad news, and honestly, I see it with my residents and my medical students. You do it once, you do it twice, and then they're kind of embarrassed not to do it. On my rounds in the intensive care unit, I have a problem list, and that includes going through, the variety of problem-based organ issues, and then we talk about pain, we talk about sedation, and we talk about goals of care. Every single patient in the intensive care unit. And in the beginning, when I start rounding with residents and medical students, they forget about it, or goals of care, he's going to be here in the intensive care unit. No, that's not what I mean. What I mean is, who is this person? What's the prognosis? Is there a family involved? Are there family issues? And I've just noticed this general change in culture over the course of a 2-week period with these residents where they start to be thinking more that way. And I just think it's just going to take time and a lot of effort. But we can do it. We just have to.
My name is Norman Postone. I'm a psychiatrist, and I work with medically ill patients in my practice and also go to the palliative care rounds. And I just wanted to underline what you said about having the conversation earlier and how important this education is to all specialists. Because I've been struck by how frequent, I certainly applaud the work you're doing in the ICU and the intensivists who are trying to deal with this, but how often people in hospital are confronted with seeing someone for the first time and trying to have this very difficult conversation when they've had a 10-year, 20-year relationship with their physician and never had this conversation. And getting the education out to that person so that the patients come in prepared, and then the intensivists are prepared as well, but half the conversation or more of it has already taken place.
Absolutely. Of course, I think that's the upstreaming. Pat Murphy said to me, she says, we're picking all these people out of the river. She says, we should go back up the river and get those doctors who were throwing the patients in the first place. I agree. I think I had a patient when I was a pulmonary fellow one day. It was the end of the day. I was exhausted. I was pregnant. I was tired. And I came in, and she kind of hobbled in with her oxygen tank. I had just inherited her in my pulmonary fellow clinic. And she was so ill and so end stage. And I knew, and she looked worse than she had the time I had seen before her. And I knew that this woman was really nearing the end. And I had 15 minutes with her, and I knew I should talk to her about a breathing machine. But she was so hopeful. And she was so happy and so proud of herself for being compliant. And I just didn't have the heart to do it. And within a week, she was in the intensive care unit. And I remember that. That was a deficiency. And yet I can't really, even looking back now, how could I really have taken any extra time with her. I had 3 more patients waiting for me. It was probably 4:30. I don't really know how I could have done it, but I was her primary care doctor, and that was my responsibility. But again, that kind of got downstreamed as well, and she ended up in the ICU dying. So it's a very tough problem to deal with.
Hi, I'm Jeremy Bornstein. I'm a psychologist, so I apologize in advance for what I'm about to say, but it's going to sound very much like a psychologist would say. I feel like there's a sort of shared avoidance, even a kind of cognitive dissonance around death. I mean, Wendy mentioned just even getting comfortable saying the word death, but just really a shared avoidance around what your story highlighted at the very beginning of this talk, which is at some level you knew that what you were doing was futile care, but it never entered your mind at the time when you were doing the procedure, and it took somebody really challenging you, calling you out to have that paradigm shift.
Totally, sure. And she'd done it many times before, and I had just blown her off.
Right, and I think that's part of it. I think the other part of it is you actually have to have the experience of being successful in talking with a patient or their family and having a different outcome as a result, which can be just as rewarding as putting in a catheter.
That's right.
Because you did something.
Yeah.
It's the same act of doing, not necessarily as glamorous as your talk, as the title of your talk suggests.
I think it's pretty glamorous.
But yeah, I do too. And I would argue that if people have an opportunity to practice, and that's what a lot of what we've been doing with this grant is really teaching the residents to practice these skills and to develop mastery and confidence. But having the positive experience is very reinforcing, and that's where people want to do it again and be better at it. Because that's the one thing I've learned about all physicians is they love to be really good. Just like psychologists, we like to be better. We like to be challenged and feel like we're gaining mastery.
Absolutely. See one, do one, teach one. But I will say one thing is, it's easy to say, oh, good death, bad death, communication and you'll have a good death, no communication, you'll have a bad death. And to this day, and I've been practicing this way for now 10 years, I have bad cases and bad situations all the time where I'm trying to really bring a patient-centered approach to a patient in the ICU, and something bad happens or there's anger. I just had a patient's family screaming in the ICU the other day about what an unethical doctor I am and how dare I tell the mother that she had cancer when she had specifically asked me she had said, what's going on? And it doesn't always go well. I will say that's a very important thing. And that's why it's important that we have lots of support. And that's what's so beautiful about a palliative care team, is that you're not alone. I have real support, and it's this incredible sort of multidisciplinary, tremendous support. When I'm in the ICU and something goes wrong, I'm alone. So it's a really important concept of a multidisciplinary team.
I mean, the avoidance goes both ways. As patients and family members, they don't really want to deal with the inevitability of death. It's a difficult subject for them to deal with as it is for us.
Yeah.
Can I suggest an amendment to the see one, do one, teach one paradigm, which is see one, do another one, get feedback, practice. I mean, that's how we learned how to do anything in life.
That's true.
And these are not skills that can be taught in a didactic form, where you read a manual or you watch somebody do it and you get some information.
Yeah.
It's like any other skill, like we learned in medical school or graduate school. You practice it and practice it again until you really feel like you've mastered something, and that's when you can go out into the world confident to have these very difficult conversations.
Yeah.
I want to add to that because Susan Block, who's the palliative care chair of palliative care at Harvard, who Atul Gawande trailed for a couple of years, she makes a really good analogy that I think is so useful, and that is that, while surgeons take a lot of time practicing a new procedure, a new operation, new operative technique before they actually go into the OR and do it on somebody. They read their book, they talk about it beforehand. We don't do that with difficult conversations with patients or family meetings. Mm-hmm. And she makes the analogy that a difficult conversation, be it about, withdrawing machines or conveying a bad diagnosis, is really a surgical procedure, and it needs to be practiced and thought about before you walk into the room. You need to know who the players are. You need to know what you're going to say and when, and to do it any other way is really negligent.
Checklist. It needs its own checklist. I wrote a piece about this very thing, about not knowing who the actual surrogate was and making a whole plan with this estranged wife when there was you have to have your facts in order before you go in and have a family meeting. Before I extubate somebody, and I extubate patients all the time in the ICU, you have to figure out exactly who's got the suction, who's got the morphine, who's got the family, who's brought a chair in, who's got the Kleenex. I mean, it's a whole, if you don't do that, it can turn into a disaster. And it really is. Obviously, with variables and things can always go wrong, but I really agree with you that you can really do this better. You can get better and more experienced all the time at doing these kinds of things if you practice.